it's a good transition to move on to the next talk by Didier about the best way to manage fluids. Should we standardize or should we use individualized protocol?
Bernard, colleagues, friends, you gave the answer yet. So I have nothing to add. It's clear that we have to separate probably the anesthesiology, the OR for people having some kind of healthy situation versus a patient who is sick, arriving to the ICU, for whom the fluid has different indications and probably different consequences. So clearly this has to be adapted patient to patient. When we see the amount of parameters which may influence the response in flow generated by the volume we give in the peripheral vein, at least one thing is sure for me. If you are just giving fluid to increase pressure, you make a big mistake. If you want to increase the flow that you don't measure finally, you do another big mistake because you play with the patient. I don't like to play with the patient. If you measure the flow, the question is, why do you give fluid? Because the flow goes up, okay? It goes up for what? To go up, to provide more fluid to the tissues, or to provide more oxygen to the tissues? In other words, should we force the flow or should we force the oxygen content to have a better delivery? And that's something which might be different patient to patient. And you mentioned, all of you, very nicely that this has to be case-to-case analyzed. So finally, I have nothing to say more. Just to say that we give fluid for many reasons, so we don't care about this. But something which is important is you want to improve circulation. What means improve circulation? I don't know. Improve the circulation of this patient because it's not well perfused, it's not paying well, he has some abnormal perfusion indexes or clinical symptoms. You want to dilate with the fluid. You want to increase the shear stress and open new small vessels. Because the second point is, what is the relation between the big circulation that you are looking for and the small one, the microperfusion within the tissue? We don't know. And then if we have something which is blood pressure, blood flow, and someone which is an index of the microcirculation, that would be nice to know if we do well or not. Sometimes all goes in the same way. Sometimes you improve the big circulation, but the small remains very altered. So finally, as you said nicely, this fluid is a drug. But it's not exactly fulfilling the cahier des charges of the drug. Finally, we have no clue about the effectiveness or the toxicity or all the stuff of the drugs, which is the fluid, on cells, on reproducible cells, in pregnant ladies or whatever. We have no clue about it, which is absolutely amazing. And finally, I look at this, for example, for the immune stuff. Are these cells neutral for the immunity? The most anti-inflammatory drug I ever seen is the saline. Better than the steroids. That's a problem. How much should we give? I don't know. Everybody is telling you we give the amount of fluid you need. Thank you, sir. I'm very happy with this. How I know that I need 4, 6, or 10 liters or more? I don't know. You have to go to check. And that is why the functional hemodynamics seems to be a reasonable approach. You go step by step. You see the clinic, you see the parameters you measure, and you give some small amount of fluid and you test. When the things are not really improving, please stop and try to think differently. And that's an important issue. The physicochemical composition of this, you mentioned nicely. Apparently, if I understand correctly, no, we have the proof that the balanced fluid for the anesthesiology patients would be better than the unbalanced fluid, the chloride, I would say. Okay? until we get a paper showing exactly the inverse, we can trust this. Okay. So if we are looking for something you want to know to make a decision for your institution, your team, or whatever you discuss about the results, so you are on evidence-based medicine. Evidence-based medicine is a real issue. So you have the patient, okay, you have the physician, and you have the information. And you have to put the three in a good shape together, which means that the physician has to be very well trained, experienced, current expertise. He has to read all the time. He has to demand for the next proof exactly what we try to do here. Needs time. And you are the doctor who is doing the job, and sometimes they are not exactly the same. You are in the OR, the guy is reading. The guy who is reading is telling you, I read this. And then you apply what he said, if you trust the guy. The patient is very different. He has to be operated for the colon, surgery, whatever, but he has a medical history which is different. And the information, where the information comes from, if you don't speak English at all, you read only the Chinese or the French journals because you speak the Mandarin. That might be different, that the information is coming from the English journals. So it's a very important issue to know where the information comes from. Then finally, if you look at the objection for evidence-based medicine, there are a lot of objections, and you have a lot of gray zones in clinical practice. Because you read the paper say, except for this subgroup, or the postdoc, or the blah, and then finally you don't know if it's applicable for your patient or not. Finally, I don't have the time to go in detail to this, but just to mention, in addition to the evidence-based medicine, which needs a lot of time to be done, you can say, I would like to use an algorithm which can be provided by the computer. And then with the computer, you put the age, the medical history, the key points, the keywords of the patient, and some information like this. And then you say, it will be operated for this. Give me your scheme. And then the machine will provide you some kind of algorithm. And then you follow this. And it works. The less educated you are, the better is the computer for the patient. And it makes sense because the goal is to reduce the malpractice coming from the unknowledgeable people, and can be unknowledgeable in many, many issues. And if I have a patient to take care, I don't know very well the disease, it's nice to get the computer telling you, please do that. It's better than I will do myself. And I agree with this, and this has been nicely shown. I don't have the time to go through, by Pierre Squara, who was using a hemodynamic computerized clinical decision-making, which is a very elegant one, and then may help the residents to improve the decision, and they change in 97% of the cases the decision they have made initially. When they use the computer data, they change totally their thinking and strategy. So finally, the striking finding was this, where a disagreement was common between the resident initial evaluation and the computer program. Good news, we have to train. And the computer is well trained because it's trained by the people who knows what they have to know. The computer assistance is inducing major changes in the diagnostic and treatment. That's an important issue too. And the high level of agreement between the senior staff and the computer is absolutely essential. And then we have this more or less for the moment. And to finish this, okay, you go to the evidence-based medicine, you are an academic guy, you read everything, you're aware about everything, and you are looking for all the things. You need to have one paper classified as a valid paper for evidence-based medicine. You need to read at least 20. Then, having a valid paper, if you want to get a paper which is providing you adequate, valid results for the patients you are taking care, you need to read 200 papers. Who has the time to read 200 papers to take care of one patient? So finally, I think that we need an algorithm to avoid the risk, and we need some people telling you what has to be done. Thank you very much.
Thank you very much, Didier. We've got a short time for some questions. I'm thanking you for emphasizing the hypocrisy of the recommendation that tells you, please make this patient euvolemic, give him adequate amount of fluid. What does that mean? What will the nurse ask me how much is adequate for that patient. So clearly, this is very hypocrite. So we need to probably use another approach for this for our fluids. And the idea, when we give drugs to anesthetize patients, we stop giving a certain number of milligrams per kilogram, but we titrate the drug until we reach the effect that we want. What about doing the same for fluids? Let's titrate the fluids until we increase the flow and stop it when the flow reaches a certain value or when it stops increasing.
I'm very happy if we can do that. If we solve a question which is not easy for me, but maybe it's easy for you, is to know why we give the fluid. If I'm following the Surviving Sepsis campaign, right? This is which is moving every 2 years because the world is moving. And you see that the CVP, for example, now it's better to be lower than 10, which is correct. And you give fluid until you decrease the lactate, which means that giving more fluid is supposed to reduce the lactate. Now that's something I don't understand well. How the fluid, the best, you recommend the best, I give the best, and the lactate goes down. Which means that maybe I perfuse better. Perfusing better, the lactate is less produced. That's probably what is behind. But it's not true. It doesn't work like this in ICU patients because the lactate is not coming essentially from hypoperfusion. It's coming from stress cells shifting the metabolism, but not for hypoperfusion. So finally, depends of the associated molecules or pathways or markers we would like to associate with the fluid we give. Quantifying the stroke volume, that's clearly no question for it. We need this. But in addition to that, depending on the goal for which we give the fluid, it's important to have some other markers associated, simple one at the bedside.
Yes, and even if the fluids will increase cardiac output, so the microcirculation, it doesn't tell you if this volume of fluid will increase the microcirculation as well.
Absolutely.
It's funny to see that you can give a sodium lactate to reduce the lactate.
Absolutely. But, honestly, I don't know if you agree with, but poor lactate guy. I mean, everybody is, lactate goes up, and the patient is better because, of course, there's a relationship between the level of lactate and the outcome. That's true. But it's not the lactate which is killing the patient. That goes in parallel statistically, but it's not mechanistically. And then the lactate goes up because you are more stressed. That's it. That if you reduce the stress by any reason, you operate, you treat, whatever, the lactate goes down, not because of the perfusion.
Thank you very much. Well, we are reaching the end of this session. Before we close it, I would like to ask you guys if we have to remember one important thing for each of your presentation, what would it be? Marc-Olivier, if you want to give us an advice about fluid responsiveness, what would it be?
Please, for the clinical practice, perhaps consider the hemodynamic challenge more than the fluid challenge, because fluid overload is dangerous for our patients. So please consider this concept.
Thank you. Emmanuel?
I don't know. In my opinion, there is no unique target, no unique value, no unique magic number. So again, it's very difficult to answer the question about the ideal target value for hemodynamic optimization. I'm fully convinced that we need to monitor our patients, and we need to monitor different parameters. The pressure, obviously, the flow, obviously, and both are very useful and obviously determinant in the for the optimization of the hemodynamic of our patients.
Thank you. Olivier?
Probably think to separate the anesthetic patient from ICU patient. Optimize anesthetic patient and try to reduce the volume of fluid that you will give to your ICU patient. perhaps you can give fluid in the early phase of sepsis, but be aware that after 6 hours or 1 day, you have to clearly follow the volume of fluid that you have given to your patient and follow the fluid balance of your patient. And the solutions, the fluids are drugs, and you have to use the good drug for the good patient. You can continue to use saline, but when you have a large amount of fluid to give to your patient, probably balanced solutions are better. And yeah, think about the chloride toxicity every time.
Thank you. Didier?
Rapidly, I support the idea that the more you know the physiology, the better you will be a good doctor. And that's it forever. Whatever the modes, the techniques, or whatever, if you understand what you do, physiologically, that's the best for the patient. The second point is the evidence-based medicine, which is essential, but sometimes is intoxicating a lot of medical issues now, especially for the large database, for simple ideas to give fluid, for example. It's not so clear, as you mentioned very well. So the validity of the trials for your patient, you have to treat day to day, makes problems sometimes. And the third point is the algorithm might be the good way, and the artificial intelligence and all this kind of new technology coming on the market now may help, not replace, may help the doctor to make a decision adequately for the patient he has.
Thank you. So, we've learned a lot. We've learned that improving the circulation is not an easy task. It's not something that can be summarized in a protocol that fits everyone. We have to remember that every patient is different, and we have to target specific aims for each patient. We should monitor our patient. We can, in certain circumstances, use a heart-lung interaction to figure out whether or not a patient will be able to respond to fluid, but there is a lot of limitations to this type of approach. We have to monitor the flow because that's what's going to be affected by fluids, but we have to keep in mind that maintaining an adequate mean arterial pressure is also essential. The type of fluid is also important. Probably the way we give the fluids is even more important than the type of fluid per se, but giving the fluid in an appropriate way and choosing the one that is less toxic is indeed very important. And of course, in the end, individualized for every patient, but we probably need the help sometimes of clever machines in order to avoid the big mistakes. That's really important. But good medicine is always tailored to each person, and we cannot provide a recipe that works for everyone. We have to clearly make the best we can for every patient. So I would like to thank you all for this great session, and thank you to the audience, and we wish you a nice, and we would like to thank you for joining the e-sfar symposium. Thank you very much.
Thank you.